So good evening and welcome to this session on Marburg virus. In this session, we will explore the key features of this highly infectious virus, including its transmission, symptoms, and potential impact on public health. We will also discuss the current state of research on Marburg virus, including the efforts to develop treatments and vaccines and the challenges that remain in the management of this deadly disease. So whether you are a healthcare professional, researcher, or simply interested in learning more about this infectious disease, we hope that this session will provide valuable insights into the world of Marburg virus. And this is a rare, serious disease that can cause hemorrhagic fever with high mortality rates. It's also crucial that we understand how the virus is transmitted, how it can be prevented, and how it's managed when outbreaks occur. So in this session, we will explore the different strategies for preventing this disease, the spread of the virus, as well as the key symptoms to watch out for in these patients. And by the end of the session, we hope that you will have a better understanding of this important infectious disease and the measures that can be taken to prevent the spread and managing the impact on the public and the society. So what I did today is that I went to ChatGPT and asked them to give me an introduction, and this is what I got from two different ones that I combined. So we'll start first with introducing the first speaker. What we want to do today is, since we know all the speakers, we don't want to waste time on taking so much time to introduce everyone. I just hope that the speakers will appreciate this. So we'll start first with Dr. Huda, who will give us an introduction into the epidemiology and history of this disease. Dr. Huda is a pediatric infectious disease consultant at SCAMC. The floor is yours, Dr. Huda.
Assalamu alaikum and good evening, everyone. I hope you can see the slide. If you can confirm to me.
Yes.
Yes, okay, good, perfect. Okay, so without lots of introduction, I will be talking about Marburg virus disease, and I'll focus on the current epidemiology, previous epidemiologic features of the virus, a little bit about the virology, and why are we concerned? What's the current concern? So Marburg virus disease is caused by Marburg virus, which is one of the filoviruses that are non-segmented, negative sense, single-stranded RNA virus. And as the name implies, the family name of the virus, the Latin phylum, is a Latin word that goes with thread-like structure or thread-like appearance, and that's because the virion itself has a filamentous structure in character. The filoviruses resembles rhabdoviruses and paramoxyviruses, and probably the more commonly heard virus is Ebola virus, which is a cousin of Marburg virus, but it has also other filoviruses that cause hemorrhagic fevers, including the Marburg and the Cova virus, which is mainly isolated in bats in Spain, but it hasn't been identified to cause any epidemics. So that virus can infect both humans and non-humans, and from non-human primates, monkeys, gorillas, and chimpanzees can be affected, and it can cause a hemorrhagic fatal disease when it comes also to animals. And the case fatality, as Dr. Ahmed said in the introduction, it's one of the most fatal diseases and most fatal pathogens. So the case fatality ratio can go up to 88%, and as an average, it can go up to 55%. And that depends on where the case was managed, the healthcare setting, and the availability of the resources as well. So you will see with while I go through the slides that the fatality would range from country to country. Looking into the genetics of the virus, more than 80 unique Marburg virus genomes has been identified, and two major lineage are known, which is the Lake Victoria Marburg virus that caused the Guinea outbreak in 2021, and the Raven Marburg virus. And there are multiple outbreaks that has happened and have been investigated to look into the lineage of the virus or the genetic variants. And in some outbreaks, it actually showed multiple genetic materials from both lineage. So not necessarily one lineage can cause a specific outbreak. And the current outbreak in Guinea and Tanzania are still under investigations to look into, and still the phylogenetic analysis are ongoing. So we don't know that yet. So Marburg virus is one of the zoonotic viruses, like other hemorrhagic virus, and it has been identified in bats, mainly the fruit bats and the what they call the Egyptian rosette bats. And these bats usually infest caves, and that's why multiple reported cases has been reported from exposure to caves through either mining or through adventurous touristic kind of visits to these caves. And I will show that as well in the next slides. However, there are some studies that looked at the infection of these bats, and some serologic studies showed that bats can be positive and can be chronically infected without showing any illness or symptoms, and can shed the virus in their secretions. So transmission from the spillover from animal to people, from bats to humans, and then go especially through contact with secretions, mucous membranes, and broken skin. Then comes the person-to-person contact. And that's again through contact with body and blood and body fluids, and especially in urine, saliva, and blood while dealing with patients with hemorrhagic diseases. And that was a case of secondary transmission among the community, either while dealing with the patient in hospitals or dealing with the bodies and burial practices in the community. And I'm sure my colleagues will cover that as well in the transmission. So as the name implies, the Marburg virus disease, the first outbreak that happened was in 1967. And in 1967, it affected two cities in Germany, including Marburg city, which I'm sharing a picture here from Marburg city, and Frankfurt. And then came some cases from Yugoslavia, Serbia, and so on. In the outbreak of 1967, almost 31 cases has been infected, and 7 was the fatality, with a case fatality ratio of around 23%. So the infected personnel were lab workers who were working on African green monkeys to develop vaccine studies. And these African monkeys were imported from Uganda. But further studies did not show where exactly in Uganda and which district, but we know that it was originated from this country. And then, of course, as I covered earlier, the further studies has been done to look into the different lineage. And we know that there are two distinct lineage, which is the Lake Victoria Marburg virus and the Raven Marburg virus. And the Raven Marburg virus was identified further in 1980s as a cause of epidemic in the Republic of Congo. In 1975, after the 1960s, to be honest, most of the outbreaks happened mainly in the African subcontinent. So in 1975, South Africa have encountered an outbreak. The source was not identified, and it was among a patient who practiced hitchhiking in Zimbabwe, and then traveled to his own village and infected his traveling companion and the nurse, and that's what caused the outbreak. In 1998, Democratic Republic of Congo, and it was identified among men who were mining in a cave that was an abandoned cave, and resulted in lots of cases in 1998. Probably the most disastrous story of Marburg outbreaks, and the most outbreak that led to lots of life loss, is the outbreak in Angola. And that was associated with more than 250 confirmed cases. It was mainly due to contamination of blood transfusion products that was used in a pediatric ward. So most of the infected people were among a young age group in that hospital. And in 2009, 2 cases identified, one in a Dutch woman bumped by a bat during a cave visit, and another one was retrospectively diagnosed after that lady being diagnosed because of similar symptomatology. The Dutch woman died, but the other one was diagnosed retrospectively through serology. And then from 2009 until 2017, mainly the outbreaks were in Uganda. And after that, the other African countries started to show some spillovers, such as southwestern Guinea. And in that outbreak in 2021, all died. And in July 2022, in Ghana, 2 unrelated men who attended same funeral, visited same funeral, died due to Marburg virus. And now in 2023, we have 2 active outbreaks, which is in the Equatorial Guinea and in Tanzania. I'll go into the details of these 2. So the 2 new countries, what's more concerning is that these 2 countries are naive countries that did not isolate Marburg virus infection previously. So it's the first time for these 2 countries to deal with an outbreak related to this very contagious and very fatal virus. And therefore, there are some results that show some community outbreak or transmission, and therefore the control is an issue. Looking into Guinea, in the 7th of Feb, at least 8 cases identified, and it was attributed to death from 7th of Jan until 7th of Feb. And then by the 12th of February, around 8 blood samples were taken only from contacts from these cases, and one of them was positive. And by March, almost 3rd week of March, 9 confirmed cases and 20 probable cases. But by April 5th, which is the latest, according to the WHO, 14 lab confirmed cases and 10 have been fatal so far. So when you look at the Guinea, it's not only the number of cases, but also the districts. It's been that has been infected. It's from district to district, and it has very close borders to the adjacent countries, which is Cameroon and Gabon, and that's a concern, especially that these borders are active in terms of travel and transports when it comes to this country. So that's a timeline of how it started from the 7th of Feb till the 9th, and isolation of the Marburg virus. And then from 21st of March, the first case in Tanzania, and Tanzania declared having 8 cases actually of death that was not identified as a cause. And then comes the concern with regards to Tanzania. Now, for WHO recommendation with regards to the risk assessment, as I mentioned, this country has, especially Guinea, has multiple districts infected, has multiple borders with other countries. So it was categorized as very high risk at a national level, with a concern of community transmission, and high risk in terms of sub-regional level, and moderate at a regional regional level, with a low risk with regards to the global level so far. In Tanzania, the first identified case was reported due to travel to Lake Victoria in Tanzania, and that was a villager who went back to his village in Bakuba and died, and then followed by 8 more cases that died due to unknown reason. And then from on the 16th of March, 7 cases and 5 deaths from unknown disease. But then by April, we know that 8 lab-confirmed cases were due to Marburg virus disease, and of which 5 were fatal, which gives a case fatality rate of around 62.5%. Looking into the 2 countries, when you look into the map, these 2 countries are not adjacent to each other. So this is Guinea and this is Tanzania. So we don't think that they are the current 2 outbreaks that are happening in the same time. We don't think that they are probably related. However, investigations are still ongoing. And we know that the main reservoir is bats, and bats can harbor different epidemiologic regions, which might affect the epidemiology. But the concern is going into the adjacent countries. So that's a global map that shows the countries that suffered from Marburg virus disease outbreaks from 1960s until 2023. So you can see some European countries, including Germany and Serbia, and then mostly the African countries has been affected. So since the 1960s, this virus did not cause a pandemic, even though we're concerned about such an outbreak. But why should we? Looking into the countries, the prevalence of the disease in countries, again, Uganda suffered the most common mortality, up to 100%, and in Germany 24%. So the fatality rate has differed from country to country, but we have learned from multiple zoonotic infections, including the Marburg virus outbreak and the previous emergencies that has aroused with regards to coronavirus or MERS-CoV-2 or arboviruses, Nipah, monkeypox. We know that we should always alert globally this should be a global public health alarms. We're open to multiple countries, and travel has been active between multiple countries, and we've learned that I think hardly through SARS COVID pandemic and the monkeypox emergency that we dealt with. So we should be cautious. We should know where the concentration, or where the countries and the districts that are suffering currently from the Marburg virus disease epidemics, and we should update ourselves through looking into the weekly report by the WHO. You can always visit the weekly report, which is a free access report, to look into the situation and how things are going. Without taking more time, I would like to thank you, and then I'm sure my colleagues will cover the rest of the topic.
Thank you very much, Dr. Huda.
Thank you.
Finished really on time. We'll move now to the next speaker. So Dr. Farhan Fadl, who's a consultant ID at SKMC as well. We'll talk about the clinical presentation of Marburg virus disease. Please go ahead.
Thank you. Am I audible, and is my slides seen?
Yes, and we can see your slides.
Yes. All right, right. So, thank you so much for the organizers to ask me to present this. It's going to be a very simple presentation because it's just 10 slides in 10 minutes. So we will focus on the most important points. So the outline for today's presentation would be on transmission, clinical features, when to suspect Marburg, and then a small summary at the end of it. It's important to know how the Marburg virus is transmitted, because that would be specific questions that you would ask a patient who is suspecting this infection. So it is usually transmitted by mucosal surfaces and breaks or abrasions of the skin, so close contact. In the outbreak situations, mostly it comes to direct contact with infected humans or animals. And there are many cases where even after death, or because of religious reasons, when the family members give bath or touch the body, and that's how the entire family gets affected. In the nosocomial setting as well, there are a lot of healthcare workers who get parentally exposed, either in the lab while handling the sample or while taking the sample as well, and taking care of these kind of patients. Human-to-human transmission is seen with direct contact with blood or other secretion. Now, it's important to understand even saliva, sweat, stool, urine, tears, or breast milk. All of these contain this virus, and therefore strict adherence to infection control measures are appropriate, and which will be dealt in the upcoming lectures. Handling of corpse during burial proceedings is a significant risk factor. There's also a possible sexual transmission, and therefore this sexual history also has to be taken in a patient who's traveling from those places. Now, this is highly infectious, and there are lethal. It's very lethal following experimental aerosol exposure, and so therefore it is a potential threat as a bioterrorism agent as well. Why this would be important is because if there is multiple cases across a large area, this is one thing that we should also consider. Now, excreta from the infected African bats might be considered as a primary route of introduction into the human population. Therefore, even when your patient comes from an African country, you need to ask them specifically if they've gone for trekking, was there an animal exposure that they had over there. Clinical features, there are CDC and WHO don't distinctly give these kind of phases, but they give a rough idea. And there was a nice paper which is out from 2011, which divides the whole clinical features into 3 distinct phases. And why this is important is because depending on what day the patient presents to us, we'll be able to figure out the classical features of this infection. So first is generalization phase, then there's early organ phase, and then there's late organ or convalescent phase. So generalization phase starts from the 1st to 5th day of clinical symptoms, in which you get regular influenza-like symptoms, which is abrupt high-grade fevers, which is also classically seen in dengue and other tropical infections, associated with headache, chills, myalgia, and malaise. Now, this is accompanied by rapid debilitation. So the myalgia and malaise is so severe that they're not able to move around, they're not able to talk and eat as well. So you could see that the patient is severely sick. Now, there's also a description of a rash which is present on the face, trunk, and extremities during this phase, which is maculopapular rash, and which can appear as measles as well. So this is the rash that you see around here. Along with this, you can also have conjunctivitis, enanthum, dysphagia, and pharyngitis, which are also commonly seen. Now, again, can you differentiate this from any other viral illness that you see? The answer is no. So therefore, your history of travel, social contacts will become very important. Moving on to the early organ phase, which is usually from the 5th day to the 13th day. In this stage, you would see there's a prostration, there's some amount of dyspnea, exanthema, and abnormal vascular permeability, including conjunctival injection and edema. There's continuous high-grade fever, and during this phase, you can also think of neurological symptoms, which is like encephalitis, confusion, delirium, irritability, and aggression. Now, mind you, this can happen in malaria, this can happen in dengue infection, this can happen in rickettsial infection as well. So therefore, your epidemiology has to be considered very, very strongly. And in the later part of the early organ phase, you can see hemorrhagic manifestation like petechiae, mucosal bleeding, uncontrolled leakage from venipuncture sites, visceral hemorrhagic effusions, melena, bloody diarrhea, hematemesis, and ecchymosis. Now, this again is common for all kind of hemorrhagic fevers. But again, if you get them in a very severe format and you don't have an alternative diagnosis, you can consider Marburg virus as one of the differentials. What about the late organ phase, usually starting from the 13th day till the 20th day? Now, this is again the critical stage where patients can have convulsions. They have severe metabolic disturbances. Now, these are the reasons why the patient eventually dies. Diffuse coagulopathy, multi-organ failure, and shock. As Dr. Huda was mentioning, different countries have different outcomes because of, if you see the people who have more experience in managing these patients would be having a better outcome. Now, the pre-agonal stage develops neurological symptoms, including restlessness, uptendation, confusion, dementia, and then eventually coma. Fatality usually occurs on the 8th to the 16th day. If you are lucky enough to recover in the convalescent phase, the survivors do have myalgia, arthralgia, asthenia, hepatitis, ocular disease, and psychosis. So first of all, the number of people who survive are less. And even if they survive, it is going to be with problems at the end of it. Now, in the examination, your aim should be to usually exclude alternative diagnosis while looking for signs of viral hemorrhagic fever, like conjunctival injection, purpuric rash, other signs of bleeding. For instance, if you expose the patient and you see an eschar, then you know this is rickettsial infection. If you see that there is a large spleen or a large liver, then it's more likely malaria. So likewise, the idea of doing a physical examination is to also look for alternative diagnosis as such. Now, you also need to understand the phases of the disease. Initially, they can have fever with non-specific symptoms. Later on, they can have febrile gastrointestinal symptoms. So you have a patient with fever and severe vomiting, diarrhea, abdominal pain. So the patient looks like a ghost, basically, where he's dehydrated, he's having asthenia, and he looks very, very sick. Again, can you just, on the basis of this, know that this is hemorrhagic fever? The answer is no. So not all patients will have signs or symptoms of bleeding or coagulopathy. And hence, the clinical judgment or clinician-based thinking is very important. Now, this is just a graphic representation of all the things that I said. So in the initial 1 to 5 days, you'll be able to see regular symptoms like fever, headache, nausea, vomiting, rash, conjunctivitis, pharyngitis. This is also the time where you'll be able to see the PCR, which I think will be dealt in the next lecture. And you see, during the 3rd or the 4th day, your platelet starts dropping. Now, initially, the leukocytes can be reduced. This is, again, common for most of the viral illnesses. And you can see that the liver enzyme starts increasing. In the second phase or early organ phase, you would start seeing the hemorrhagic features, dyspnea, edema, and aggressive behavior and CNS symptoms. Again, during that phase, platelet starts dropping, inflammatory markers start increasing. And towards the last phase, where you will see more severe metabolic issues, which eventually lead to septic shock and death. I would also want to focus here on social separation, because these patients are almost thought of about to be untouchables for the entire duration that they are there in the hospital. It's physically and mentally very, very difficult to handle this situation. So when do you suspect Marburg disease? So think of clinical features of hemorrhagic fever. There are many differential diagnoses, so you have to make sure you rule them out. For instance, leptospirosis, malaria, rickettsial fever, dengue infection. Very, very important is to ask travel history and contact history. Now, I want to reiterate this point again and again, because in a country like UAE, there are so many travelers coming from so many countries. You need to know not just the last country that they have been, but also the countries that they have been before that. As we mentioned, the incubation period is 21 days. So that's the cutoff usually in most of the guidelines where you want to consider the disease. What I mean to say is, if the patient says, I've come from, say, Uganda, but it's been 2 months, it's very unlikely that the current hemorrhagic fever is because of Marburg or Ebola virus. So therefore, this 21 days of incubation period is very important to keep in mind. Also, sick contacts, because you know that human-to-human transfer is possible. You would see that USMLE questions and all the exam questions also would mention this. If there's a religious leader or a nurse or a doctor who's been in Africa, taken care of sick contact in the hospital of patients, and they come back to their original country and then show signs and symptoms of hemorrhagic fever, you need to consider this disease as well. Now, CDC case definition, I think will be discussed, but I would want to focus about the signs and symptoms. So if you have a patient with fever and any of these symptoms, that is headache, muscle ache, vomiting, diarrhea, abdominal pain, or thrombocytopenia, and you have this epidemiological linkage, like for 3 weeks before the onset of symptoms, there is exposure to blood or body fluids with viral hemorrhagic fever. There is residence or travel to a viral hemorrhagic fever endemic area. There is, if you are a worker in the lab which handles these specimens, or you are a veterinary doctor or person handling in the veterinary side where you're handling bats, rodents, or primates in an endemic country. Sexual exposure to semen from a confirmed or a clinically recovered case of viral hemorrhagic fever would be the reason you would want to consider this infection. In summary, clinical suspicion is very important because clinical features may be confused with malaria, dengue, or other tropical infections. Now, I want to mention here we had a patient where there was a patient who came from Ebola. Obviously, initial suspicion was there, but the patient was found out to malaria positive. Now, at this juncture, people can argue, should we still work up for viral hemorrhagic fevers, or should we just treat the malaria infection? Now, again, if the patient is clinically getting better on your malaria treatment, then there is no need for suspicion for viral hemorrhagic fever. Now, there is a theoretical risk that a patient might have both infections together, and therefore it is prudent to rule out these kind of infections in all kinds of patients. Again, it depends from the center you're working and how clinically suspecting you are about this disease. Travel history and exposure history is vital for diagnosis. Now, this starts as non-specific febrile illness, but rapidly progresses to hemorrhagic complications and eventually septic shock-like syndrome. Death is due to multi-organ failure and shock. Survivors have a protracted recovery and variety of complications, both physical and mental. And with that, I would like to thank you with this pictography from the CDC, which mentions that you can have very regular common issues like fever, headache, diarrhea, vomiting. Fluid replenishment is very, very vital for the management of these kind of patients. And I'm sure this will be dealt in the diagnosis and management of Marburg disease. With this, I would like to thank you. And hopefully, if you have any questions at the end of the session, we'll be able to discuss them. Thank you.
Thank you very much, Dr. Farhan. And as you said, we will have the question and answer session at the end of all the sessions.
I just want to ask the IT team to fix the screen for Dr. Farhan, because the screen looks like infected with Marburg virus. So yeah, this is like manifestation of the disease. We need to fix that. So IT team, please work on that so it does not happen again.
Okay, Dr. Farhan, please close your camera and open it again.
Thank you, Dr. Omar.
Thank you, Dr. Farhan. Thank you.
With that, we'll move to the next. Amar, shall move to the next speaker. Dr. Stephen Weber, well known, doesn't need any introduction. He will give us a short overview on lab diagnosis for Marburg virus.
Yeah, good evening, everybody, and thanks for inviting me. And as was already pointed out, Marburg is pretty much like Ebola, and many of the lab diagnoses that I present to you are also from the Ebola experience. So these are the viruses of the viral hemorrhagic fever family, Arena, Philo, Bunya, and Flavi, and we will concentrate on this family, especially on the Marburg virus. Dr. Farah already mentioned the laboratory findings, so I will quickly skip that. Thrombocytopenia was mentioned, and the leukopenia followed by leukocytosis. Also like to point out the electrolyte abnormalities because of the fluid shifts, the significant fluid shifts that you see because of the bleeding. But what I would like to emphasize also is the risk assessment, because of the nature and the infectiousness of the samples. Healthcare personnel and also laboratory personnel is at significant risk in getting infected by these samples, because most of the time it is blood. We also learned already that almost every fluid that comes out of the infected patient is a danger for healthcare personnel. Also like to point out that patients are not infectious before they have symptoms, so that is also important to realize. But to give you a dimension how infectious this really is, Ebola/Marburg virus disease only takes 1 to 10 viral particles to infect a human being, and 1 to 10, if you think about the size of a virus, that billions of them fit on a pin, on the top of a pin. That is truly an impressive pathogenic feature of a disease. And as a comparison, influenza A at least needs 800 viral particles to infect you, and norovirus, which also is highly infectious, needs at least 1,500 particles. So, and if we make a range of severity, that was also already mentioned, then Ebola Marburg is by far the most dangerous one. Then followed by Crimean Congo hemorrhagic fever, and then dengue fever. So those are the hemorrhagic fevers which can be expected to see here. As Dr. Fahad also mentioned, that there are important differential diagnoses which you need to consider because it's sometimes impossible to separate them. So whenever you have the suspicion of viral hemorrhagic fever, you must look at least for malaria, things like typhoid fever, and causes for bacterial and viral diarrhea. So it was already mentioned about the risk and the exposure, but I would like to show you this workflow, which is part of our clinical pathway for Ebola disease, but it's the same like Marburg. Now, what you can see here is that this is basically a two-colored screen. We have the yellow and we have the orange, and what you do with this screen, with this scheme, means that you assess your patient whether it's low risk or high risk. Now, this is important. This classification is important because it tells you how to handle your patients further. It's also important to realize that it is very, very important at an early stage to contact the people in the hospital who deal with infection control, the microbiologists on call, and the involved health authorities. So what you also can see, and I tried to make my screen a little bigger, is that you have these three basic questions, A, B, C, and that was also mentioned previously, but I want to emphasize that. And the N's are fever and travel history, or fever and exposure and travel history. Now, if neither of them is present, then there is literally a very low possibility of Marburg or Ebola viral hemorrhagic disease. And if you have a patient in category B or C, so with exposure, you would automatically classify him as a high risk. And high risk means that these samples have to be dealt with in a different way. You should not deal with any samples, not only diagnostic for Marburg disease, also not routine clinical samples. You should not deal with them in your own lab in a hospital without having safety precautions. So what we usually, and this is a short screen of how Marburg goes, and we have viremia, which we will diagnose with EDTA blood, and then later the antibodies come up. Nothing surprising here. And what we offer in the country is we have only a PCR. It is also possible to culture the virus. It's actually not that difficult, but you need a laboratory of the highest safte level. That's the ones where they walk around in these astronaut suits connected to outside oxygen support and the like. So we don't have that yet. So we have maximums biosafety level 3. So we can handle patient samples there, even those with a high suspicion. We do not perform serology yet because the requests were so rare that we decided if it's an acute phase, the PCR should suffice, and then serology can be sent out. So it is almost vital that you inform your lab reception or the lab reception at SKMC, where most of the samples will be referred to, about the arrival of the specimen and the diagnosis, this suspicion of Marburg viral hemorrhagic fever. Our reception personnel is trained that they will not accept any any specimen without prior approval, just one of our consultants, ID consultants or microbiology. As I mentioned before, the preferred sample for Marburg is EDTA blood for the PCR. To give you an idea how we will handle this, we have designated staff, and it will then be transported to our BSL-3 lab inside the safety bench. The sample will be disinfected with bleach, and then we will inactivate the sample. Now, that is not a problem if you only want to perform a PCR. But if you have samples where you want to perform routine chemistry or coagulation, inactivation, especially heat inactivation, can influence these samples. So, and this, in other words, these samples remain highly infectious if you want to do some meaningful investigations with them. So that is an important fact to have in mind. The specimen will then be handed over to one of our senior staff in the respective departments once we have inactivated it, because then you can move it out of the biosafety level 3. So there is a little difference between high-risk patients and low-risk patients, how you handle the samples. Of course, for high-risk patients, you have much stricter criteria because the risk is much higher to get infected. So microbiologists on call must be informed. Blood transfusion for both high and low will be group O uncross matched, and there will be no cross-matching in the blood bank, because that is a manual procedure and poses a significant risk for the personnel involved. The specimens will all be processed in the BSL-3 safety cabinets, and these safety cabinets are also called glove boxes. I'll show you one in a moment. And you can see that this is not present in every lab, only in specialized labs. And they also will be autoclaved right upon test completion. So we will not save the specimen for a longer time. We will discard them immediately after the test is done. It goes without saying that you shouldn't use any pneumatic tube system to transport these specimens. So these are the tests or the procedures which we recommend to do high risk. And what you should keep in mind is that none of these high-risk specimens should go in any lab automat, because they can be significantly contaminated, and after that will not be possible to use for regular patient samples. Also, the clinical waste that comes out of these instruments might pose a substantial risk for the involved staff. So malaria, we would do only the antigen test performed in BSL-3, and there will be POCT chemistry and POCT coagulation. So if you can make this sure in your own hospital, it would be possible, but I would not recommend it in a high-risk patient. And I'll show you a solution a little bit later. So inactivated samples, as I mentioned before, can be taken out of BSL-3 areas. But chemistry and coagulation cannot be inactivated. So low-risk patients is similar in terms of informing the microbiologists and doing blood transfusions and unpacking the specimen and autoclaving. So that's pretty much the same. What is different here is the tests which can be performed. For low risk, we will accept that these specimens go on the machines, but we will not do any extensive handling outside our machines. So CBC can be done, malaria will be done, routine chemistry and routine coagulation, as long as it can be automated. Also infectious disease serology and blood cultures. And the same is true here, that any inactivated sample can be handled as a regular sample in BSL-2 areas. What is important to realize is that any sample that has suspicion of Marburg or Ebola your staff in the lab needs to dress up properly with the waterproof disposable coverall, a 95 mask, a plastic face shield, double gloving, and shoe covers. And it looks, this is a picture of Ebola, how healthcare personnel goes with it. But you see already that in westernized countries, usually they go with these hoods and have an outside oxygen supply. And this is a so-called glove box. So you can see that it's completely closed to the outside. You slide in with your hands into these rubber gloves. It's not easy to handle the sample. It's there, so we try to get it out as quickly as possible, and that's why we do the inactivation step. This is a picture of the inside of our BSL-3 labs. You can see that here we have the glove box, and if it's done here, we can move over to the other a lower biosafety level bench. So that's a picture of how a laboratory personnel should look like when they handle these samples. And you can imagine that you would not let your most junior staff do that. So we say that only supervisors, sometimes even the trained senior techs, should be able to do it. Here you see them sitting at the workbench. But the other thing I want to mention is that the DOH now bought a mobile unit. So for every high risk suspicion, I would suggest that this mobile unit is contacted. You do this through the DOH health officers, and they can come to your hospital. They have is completely BSL-3 capable inside, and we are also capable of doing the basic chemistry, hematology, and coagulation tests there. But you see that it's not really cozy inside. These are the engineers who are installing it inside. That's the BSL-3 section of that unit, and this is a picture of the AC in the back, so there's no risk. Everything that goes out will be filtered, and the liquids will be collected separately and then autoclaved. So that is a possibility once you have to deal with a patient who cannot be transported to another facility, for instance. Environmental, I just will mention this quickly because I think infection control have a different talk. Hand disinfection with an alcohol-based hand rub, decontamination with the common household bleach in a 1 to 10 or 1 to 100 solution. It very much depends on the manufacturer's instructions because bleach is not always nice to delicate surfaces. What I also want to mention is that the survival of the virus is very much depending on the circumstances, whether it's naked on dry surfaces or whether it's shielded by proteins or blood. So you can say as a rule of thumb, 3 hours on dry surfaces or daylight, and 3 days under protein detection. So 3 days, if you have a blood-stained environment, is a significant time that the virus remains infectious. Last slide is truly that I show you how the package should be, the sample should be packed once it's transported. It's the triple packaging, and you can receive that. Here you see the number of our SKMC lab reception. Once we have a patient who is suspected to have the disease, you can order this there. And you see that there is a layer of protection, 1, 2, 3, so that we make it as safe as possible to transport it. So in other words, when you want to have a movie, you will contact these guys. If you have an outbreak to talk about this, you contact this guy, and this is my email. Thank you very much for your attention.
Thank you very much, Dr. Stefan. This was very well concise and comprehensive at the same time. We will move now to Dr. Nawal Al-Kaabi to discuss about management and prevention of Marburg virus. The floor is yours, Dr.
Assalamu alaikum. Can you hear me?
Alaikum salam. Yes, Doctor, we can. Go ahead.
Okay. Thank you so much, Dr. Umar and Dr. Ahmed for the invitation. So I'm going to focus on the management and vaccine development. So the main objective is to review both the management and updates on antivirals, monoclonal antibodies, and vaccines development. So unfortunately, there are no approved specific treatment for Marburg virus disease. However, the management relies mainly on aggressive supportive care to prevent the development of shock. And it's very important, and I think Dr. Emmanuel will cover this part, to follow the infection control precautions when you manage those patients. In terms of supportive care, we have to prevent the intravascular volume depletion. We have to correct the profound electrolyte abnormalities, and we have to avoid the complication of shocks. Of course, that include antipyretic, analgesics to manage pain, antiemetic to control the nausea and vomiting, antimotility to control the diarrhea and minimize fluid and electrolyte loss, antiepileptic for those with seizure, blood products for patients with coagulopathy or volume depletion, TPN to support the patients, and renal replacement therapy. In terms of treatment, in 2015, a group of researchers isolated B cells from a Marburg survivor patient and created a panel of monoclonal antibodies, which they tested in laboratory animals. So, a study showed that a single dose of the monoclonal antibodies that was designated as MR191N, given 4 days post-challenge, was able to prevent the death of the pigs infected with either Marburg or Raven virus. The same monoclonal antibody protected macaques when given in 2 doses on day 5 and 8, and otherwise lethal challenge with either virus. So without the monoclonal, if you inject those animals with that dose of the virus, it will be lethal. So this is very promising. Then there was also other studies in animal to look at the favipiravir. So study showed that favipiravir inhibit the Marburg virus replication in cell culture. It also reduced the viremia in infected mice, and it provide complete survival in infected mice. So this is another promising drug in the preclinical trials. Another study showed that twice daily intravenous dosing of favipiravir resulted in 83% survival following Marburg virus infection, while all untreated animals died. Then there is another promising antiviral, which is remdesivir. So the remdesivir was also tested in preclinical, and it showed that it prevents the death of 5 of 6 macaques animals or monkeys when given once daily for 12 days following an otherwise lethal challenge with Angola strain of the Marburg virus. Another study also looking at a new broad-spectrum anti-RNA virus called galidesivir. So the galidesivir, it is a potential broad-spectrum drug against RNA viruses, and it's been evaluated in animal studies. So it showed that it is efficacious in the pigs challenged with either Raven variant or Moscow strain of the Lake Victoria variant of Marburg virus. the Galdeservir also completely protect the monkeys from Marburg virus infection when administered as late as 48 hours after infection. So this is another promising drug. What about combination therapy? So a researcher examined the advantage of utilizing a combination therapy, which consists of monoclonal antibodies and remdesivir in non-human animals model. So while administering either human monoclonal antibodies or remdesivir to the monkeys 5 days after inoculation resulted in protection against the lethal infection, no animal survived when either treatment was initiated day 6 or after that. And as you've seen earlier, it is in phases. So we might miss the patients in the first 5 days, especially most of those patients might present it like any other viral diseases. So in this study, which is still in animals, the finding demonstrate that combining monoclonal antibodies and remdesivir starting 6 days post-inoculation resulted in significant protection, about 80% effectively. So this extends the therapeutic window. Instead of limiting it to 5 days, even after 5 days, if you give combination, you can save 80%, but again, this is animal studies. What about the vaccine? Now, unfortunately, there are no approved vaccine for the prevention of the Marburg virus disease, and those used to prevent Ebola virus disease will provide no benefit against the Marburg. And until vaccine, of course, is available, we need a strong public health response to control the outbreak. But let's go through some of the preclinical and early clinical studies. So there is a lot of efforts organized by WHO and different institutions and R&D centers, and there are 3 candidates for vaccines. There's the recombinant vesicular stomatitis virus vaccine. There is the prime boost strategy with recombinant adenovirus vaccine, followed by a recombinant modified vaccine and Akara vaccine, which is used for monkeypox, and a recombinant chimpanzee adenovirus vaccine. So in 2005, a single inoculation of the recombinant vesicular stomatitis virus vaccine encoding the viral service glycoprotein, otherwise lethal challenge with the Moscow strain of Lake Victoria Marburg virus. So this protect the monkeys that receive it. The following year, the same vaccine was found to provide post-exposure protection when administered 24 to 48 hours after the virus challenge. And similar efficacy has been demonstrated against the Angola variant using a vaccine encoding the Angola glycoprotein. A subsequent study found that a 1,000-fold lower dose of the same vaccine was equally protective. The VZV, there was a collaborative group, has subsequently developed a quadrivalent vaccine containing recombinant VZV encoding the service glycoprotein of the Marburg, Angola, Zaire, and Sudan species of the Ebola and Lassa virus. And the vaccine protected the macaques against challenge by each pathogen. The serum IgG and neutralizing antibody response specific for all 4 glycoproteins were detected in all vaccinated animals. And there was a modest and balanced cell-mediated immune response specific for the glycoprotein was also detected in most of the vaccinated animals. And regardless of the level of the glycoprotein immune response detected after the vaccination, all immunized animals were protected from disease and death following lethal challenge. So this is a very promising vaccine, and hopefully soon we will see clinical trials. There is another vaccine, adenovirus, with MVA, the modified vaccine virus Anakara vaccine. So a multivalent antifilovirus vaccine encoding the glycoprotein from Zaire Ebola virus, from Sudan Ebola virus, from Tay Forest virus and Marburg virus has been developed. And these glycoprotein are expressed by adenovirus serotype 26 and 35 and in the MVA vectors. So those monkeys receiving the combination vaccine were protected against all the viruses. And finally, there is phase 1 studies of the adenovirus and MVA combination against Ebola and Marburg virus in both adults and children have been conducted in Sierra Leone, and there was no safety concern identified. Another clinical trial tested combined chimpanzee adenovirus vector after single vaccination. A glycoprotein specific response was detected in 95 to 70% of the participants at 4 and 48 weeks respectively, and no serious adverse events observed. The last one, I think it was done in US. So there are a few few clinical trials, most of the trials so far preclinical, and hopefully soon we will see a larger study like phase 2 or phase 3, especially with the current outbreak. So unfortunately, as I said earlier, there is no vaccine, and we have to follow strict public health measures. There are different candidates, as I explained, the recombinant vesicular stomatitis virus vaccine prime and the recombinant adenovirus with followed by the vaccine Ankara vaccine, modified vaccine Ankara vaccine, and the recombinant chimpanzee adeno vaccine. And there's a future development might also include mRNA vaccine, and hopefully we'll see soon a successful vaccine to stop and prevent the lethal Marburg virus disease. Thank you so much. I think the questions will be at the end.
Thank you very much, Dr. Anwar. This is very nice and very informative. We'll move now to the last session by Dr. Emmanuel, consultant infectious disease at SSMC, and Ms. Jennifer DeQuito, infection preventionist, to talk about infection control.
Thank you very much for that, and apologies about the technical difficulties at the beginning. So I'm going to talk about infection prevention control and principles, and then Jennifer is going to bring it home with PPE, waste management, and also cleaning and disinfection. So Marburg viral disease, as we've all heard, is a significant threat because of the outbreak, because of high mortality, and there is a potential for a patient with Marburg viral disease to turn up in any of our healthcare facilities in the UAE. So at the end of this session, you should be able to appreciate the importance of emergency preparedness and planning, what needs to be done within your healthcare facility to protect staff and patients, and then the principles of looking after a patient with suspected Marburg disease and reducing the risk of exposure and transmission to your staff. So we've all, I think, by now concluded that Marburg disease is a high consequence infectious disease because it causes an acute infection, has an ability to spread rapidly in the community and within healthcare facilities if not managed properly and the right measures not taken. It has a high case fatality rate of up to 88%, high morbidity as well. Its diagnosis depends on tests, PCR in reference laboratory, so it's not in any local laboratory in private hospitals or other hospitals. It's in a surveillance or reference laboratory. It also does not have any effective treatment, as Dr. Nawal has just outlined. It's mainly supportive care. And to prevent an outbreak and spread, we need coordination at national level and effective infection prevention control measures. So it's a high consequence infectious disease by definition. And so I want you to imagine that you, in your emergency department, a 25-year-old gentleman turns up after returning from the Bata district in Northwest region of Equatorial Guinea 14 days ago. And as you will remember from Dr. Huda's talk, the Bata district is the epicenter of the outbreak in Equatorial Guinea. So returned 14 days ago. He turns up at the emergency department with a 2-day history of fever, arthralgia, myalgia, and rigors. However, he doesn't report any contact with anyone who has been ill in Equatorial Guinea. So the question is, how can you care for this patient effectively and safely in your hospital? And what are you going to do? Are you going to manage this patient as potential Marburg, or are you going to decide to assume it's malaria, investigate, treat, and if they don't get better, then start ruling out Marburg? And the answer is no. You manage this patient as a suspected case of Marburg viral disease, and you may end up treating them for malaria, but you do not treat for malaria first and then later on expose people. After expose people, start excluding malaria. So the principle of care for a patient with high consequence infectious diseases is we protect ourselves and our staff so that we can then save lives. We don't expose staff and potentially to a lethal infection and end up with an outbreak and losing staff. And so the first step is case identification. If you don't identify potential patients, then you cannot move on to the next steps. And so you need to know your epidemiology, and I'm reinforcing this as well from Dr. Farhan's talk. Incubation period is up to 21 days, and you have to ask about travel history. So make sure your emergency department has triage point travel history taking. And if they pick up a patient with a viral illness, febrile acute illness, within 21 days of travel to Equatorial Guinea or Tanzania, where there's current outbreak, then they need to suspect Marburg viral disease. And if they have risk factors, such as exposure to blood or other bodily fluids from a patient who suspected or has died as a result of Marburg viral disease, or they come from risk groups such as healthcare workers, family members, caretakers, traditional healers, or those participating in burial rituals in countries where there's an outbreak, that's a high-risk group. If they're visiting caves also or mines where they may be in contact with the Egyptian fruit bat and secretions from the bat, contact with infected animals or bushmeat, so it's usually bats and apes, all these risk factors, we put this patient in the case of a probable case of Marburg viral disease and higher risk. So the first step to be prepared is to identify a patient with possible Marburg viral disease, is taking a good travel history, coming from an endemic area within 21 days. You need to isolate the patient as your next step in a negative pressure room and use the correct PPE, which Jennifer will come to, and then inform the right people. Notify your infection prevention control team, notify Department of Health, your ID team if you have one, or your local ID unit, and manage the patient as if the patient has Marburg viral disease to minimize exposure. Don't expose staff and hope for the best. In your hospital, strongly recommend that you also develop a pathway which simplifies for your healthcare workers in your institution what the different steps they need to go through to safely identify, isolate, inform the right people, and manage a patient with suspected Marburg viral disease. And this is an example of our own pathway within SSMC. And there are really important principles when you're looking after a patient with high consequence infectious disease in order to protect staff. The first is that you have to think through your investigations. Do not request unnecessary investigation. We use clinical acumen. I'm talking through this with the experience of working in a high consequence infectious disease unit in Liverpool. You use your clinical acumen and you only request tests that are going to change your management. You don't just request random CRPs and procalcitonin that will not make any difference to your management. You only request a test that will make a difference to your management. And in some cases, you decide to treat empirically whilst you're waiting for the high consequence infectious disease such as Marburg to be eliminated. And so you may, if you cannot get a point of care test for malaria safely done, you may decide to just treat for malaria and wait for the exclusion of Marburg, or give antibiotics and observe the patient. Examine the patient and look for the focus of infection. If it's pneumonia, treat for pneumonia. You do not need an X-ray to make a diagnosis. Again, avoid unnecessary face-to-face interactions, and you have to also plan who will go in to see the patient. So not to send a nurse every few hours and doctors also going in every few hours. So you would decide as a team who will go in first to see the patient. The nurse may go in, do some things and come out, and later on the doctor goes in. The doctor may also go in and do other parts of care, like taking vital signs or even taking food to the patient at the same time they're going to see the patient. So that you don't send a nurse, a doctor, and a support service staff or caterers just to go in and potentially expose themselves. So you work as a team to decide who will go in, use technology as much as possible, phone and video calls, so that you only go in face-to-face when necessary, and you cluster care, so your team is functional. And one member of the staff going in can go in and do multiple things, not doctors, nurses, and other people going in as parallel lines. And so the key steps for preparing in your healthcare facility is forming a multidisciplinary group, identifying and training your staff in high-risk areas, emergency department, especially in telemedicine critical care areas. You may also need to train a number of highly skilled staff who will support the frontline staff, and then educating your staff by briefing them by emails, face-to-face meetings, and also face-to-face encounters and meetings, and then develop a pathway within your hospital, right from ED to a ward if they're going to be admitted, or critical care when you're looking after a sick patient, and then do a dry run and learn the lessons from the dry run, test your systems, and then refine and improve. And an example of a well-developed high consequence infectious disease system and service is in, and I want to highlight this service in England, is we have designated high consequence infectious disease units, one in London, one in Liverpool, one in Newcastle. And they admit patients with suspected high consequence infectious diseases, not just confirmed, because they take the risk out of the system, so that private healthcare facilities and other smaller government health facilities do not run the risk of exposing healthcare workers and their facility. And so they are funded, so they need adequate funding, staffing to receive, safely assess, treat high consequence infectious diseases such as Marburg, with adequate ID physicians, nurses, and other specialties. And they should also have the facilities to look after critically ill patients with high consequence infectious diseases, because the critically ill patients are the ones that are at most risk of transmission. And so you can't leave a critically ill patient in a remote place and the high consequence infectious disease unit not looking after the critically ill patient. So they have to also be able to look after critically ill patients and pediatrics also. And also are set up to do research. So Dr. Nawal has highlighted potential drugs, vaccines, etc. Well, that's really the role of a high consequence infectious disease unit. So they prepare for what if we have a case, and so they can also be involved in trials and also in education and training. And we have Arakba and Alain that do this also really well. And I highlight this because I guess there are also some issues with that they may be able to also to develop even further and also learn from other areas that do this well, such as the English High Consequence Infectious Disease Service. And I want to thank the Infection Prevention Control Team at SSMC and Tropical Infectious Disease Division for all the work that they've done to set up our own system to look after patients with potential viral hemorrhagic fevers. And I'll now pass the floor to Jennifer to take it home with PPE and waste management and cleaning and disinfection. So Jennifer, over to you.
Jennifer, can you hear us?
Jennifer, you might be on mute, so you have to unmute and put your presentation on slideshow. I see you're just about to do that. Great.
Yeah.
So good evening and thank you for the invite. So I'm here to present the PPE and the cleaning disinfection. So the objective of this presentation is to emphasize the importance of training, practice, and use of trained observer to ensure the safety in donning and doffing process of level 4 PPE. Review safe handling and proper placement of the patient. Discuss the proper waste management, cleaning and disinfection of used equipment, and environmental services. So we are placing the patient in airborne isolation room. So we have to make sure that the patient will wear the surgical mask. Any patient confirmed or suspected case of Marburg virus presented in your facility should be placed directly in isolation room. Visitors are restricted from entering the patient room. Exception may be considered on case-to-case basis. Maintain a record of all persons entering the patient room, including staff and visitors. So for patient transport, traffic control shall be done during patient movement. The lift will be dedicated to the patient and escorting staff only. The housekeeping staff shall clean and disinfect the lift, recommended chemical soon after the patient transfer. Moreover, the lift shall not be used before cleaning and disinfection. The housekeeping staff wear the recommended PPE level 4 for level 3, for cleaning and disinfection. As you can see on the slide, we have already the pathway and we have the dedicated elevators in all our towers if we are receiving the suspected and confirmed Marburg virus patient. So for cleaning and disinfection, use hospital-approved chlorine-based disinfectant for terminal cleaning. Fumigation should be done after terminal cleaning, and the room should be kept closed for 1 hour so the proper circulation will be there in the room. So for the waste disposal, all type of waste, including food waste from the patient room, shall be placed in the double red plastic medical waste bag and treated as highly contagious medical waste. All waste generated in a Marburg virus patient room shall stay in the room and should not be stored in any other holding area. When medical waste transport arrives, environmental service staff will collect all the trash and deliver it directly to medical waste truck. But the environmental service should wear the level 3 PPE, which I will show you later. So for the linen management, when handling soiled linen from the patient, meticulous compliance with the recommended PPE, all used linen, either disposable or textile, should be placed in a double red plastic medical waste bag and immediately disposed as highly contagious medical waste. So the staff also should know what to prepare when they are wearing the level 4 PPE. So the staff should change into surgical scrub suit. And in our facility in SSMC, we have this popper machine. This is the purified air purifying respirator. And this is the Bursaflow. This is the one in replacement of the N95, which Dr. Stephen is telling before we have in SSMC. So we have to prepare also the coverall, the hood, the high leg boots, and we prepared our own checklist for us to guide the staff who are entering the room. And also with this level 4 PPE, they should have the trained observer always to maintain that the staff will be going inside the room safely with the proper use of this level 4 PPE. And we have to use the high-risk gloves. So it will be double glove, and also they should have the tabletop sanitizer. Only in this PPE, we are allowing the healthcare provider to do the hand hygiene with the gloves. And also we should have this hospital wipes approved disinfectant. And also we should have 2 chairs for clean and dirty chair. So we have to identify in our facility the donning and doffing area, which we should label it as a red or green for donning and red for doffing the PPE. In our facility, we are doffing outside the anteroom, and outside the anteroom, we are donning our PPE. So for the level 3 PPE, the only difference here is the use of N95 and the goggles, which other facility, if you don't have this proper machine, this is the one we can use as alternative in to keep our staff safe, to give care to the Marburg virus patient. So the take-home messages. So meticulous infection control practices is responsibility of all healthcare workers. Know the appropriate PPE and use the available resources in your facility. Do your training and competency to keep you safe. Know the right size of your N95 by doing fit testing. If your facility is not doing N95 fit testing, always remember to perform user seal check to ensure your N95 is well fitted. And always remember to do hand hygiene with proper technique. And also, just want to share with you, we developed a training video for the level 4 PPE for our staff to be competent in doing the level 4. And also, we started the training last year for this level 4 PPE. And thank you for the invite.
Thank you very much, Jennifer, for this presentation. I don't want to take much of your time. I'm going to move to the question part, and we'll just go around the table and try to cover as much questions as we could. But before that, I just want to thank the speakers for their wonderful and concise presentation. It's very rich, very informative. And I don't think we need to read anything about the topic after attending this session, which will be available as on-demand video later on. So I will start with the first speaker, Dr. Huda. So when you mentioned that the Marburg virus is very fatal, what are the good and bad prognostic factors when treating these cases? Like, is the poor conditions in Africa is contributing factor to having a poor prognostic factor with the patients?
Thank you for the question, Dr. Umar. They looked at the genetic variants of these viruses, and fatality has been seen in multiple genetic variants. So it's mostly not related to virus factor itself alone. However, also the availability of resources and the management of those cases. And we've seen the difference between different African countries, even in management and in fatality rates, where you see some countries suffer higher fatality rates than others. I think it's a question that needs more research as well and more studies, but that's an observation.
Yeah, because you see, when we heard about the monkey virus, the mortality rate was in Africa about 10%. But when we started to see the cases here in UAE, that was totally different from what was noted there in Africa. Dr. Farhan, you mentioned about the mode of transmission of the disease. So is this disease an airborne disease, and should we take airborne precautions?
Only if you are, I think, only if you are able, if there is any aerosol generating procedure as such. But otherwise, the droplet and contact precautions are usually enough. Unless you're doing an airborne procedure, I don't think there is airborne required. But yes, contact precaution is the most vital thing. And I think if anybody wants to, the whole gist of this presentation is the PPE, how to wear and remove the PPE, I think is the most important thing. With Dr. Emmanuel and their team is doing fantastic job in that thing.
Okay, thank you, Doctor. Dr. Stephen, you mentioned in your presentation that we only have PCR testing in UAE. So is it the best accurate test worldwide, or would the tissue culture or other tools will be more accurate in diagnosing the disease?
So for the immediate diagnostics, the PCR is the best you can offer. Yeah, that's why we've chosen it. Even the viral culture would only culture viruses or be positive for viruses with a high viral load, for samples with a high viral load. So it could even be that you have false negatives with the viral culture. And the other problem that I mentioned is that you need a BSL-4 facility to do that. We decided not to go for serology at this point because requests are so rare. The pragmatic approach would be to diagnose the acute diseases first, that we decided at this point not to have serology. So PCR is definitely the best you can get.
Okay, thank you. Dr. Nawal, I received one question that if we receive a case of Marburg virus in UAE, God forbid, of course, would you prefer using favipiravir or remdesivir in such cases? Of course, we have a huge experience with these medications because of the COVID. So what's your intake with this question?
Well, we all need to remember that there is no approved treatment for Marburg virus disease. However, I think will be the decision of the infectious disease physician who will be involved with the case. But personally, I'm going to use antivirals as off-labels and observe the response. So it could be based on if it is too early, which I doubt that we'll be able to diagnose a case too early. You could consider favipiravir, but if the patient is symptomatic and sick, I will go with IV remdesivir and observe the treatment. I'm hoping with the current outbreak, we will have some results soon to learn more about what is the best management.
Inshallah. That's taking me to the next question. What's the treatment window for Marburg virus?
So again, there's no treatment, unfortunately.
Yeah, of course.
Yes, the animal studies showed that there is a good response if you start a treatment within 5 days of the lethal dose. So that's probably similar to, I don't know if it is similar to 5 days of symptoms. Ideally, actually, will be 5 days from starting to have the disease, which will be very difficult. So I will go with the earliest, the best. So if you suspect it and it will be a lot of time until you get the result, you might consider starting treatment. It will be easy to stop if it come back negative than to start when it is too late. And we don't know if it will work or not if we start early, but unlikely that it will work if we start late. So if we start early, maybe there is a possibility that we might save the patient's life. But if we start late, I think we don't have a chance to save the patient. Hopefully we will have monoclonal antibodies, because making monoclonal antibodies nowadays, it's relatively easy So with the current outbreak, I hope the pharmaceutical will make monoclonal antibodies. You know, when I reviewed the management, I become more or less angry, honestly, because it is not fair not to do proper work, especially with a disease that started in 1967, and most of the publications still animal study, although, and the animal studies, it's extremely beneficial. So I don't know why they didn't move to the clinical trials to test different options, simply because it happened in Africa, unfortunately. But
And same goes for
yes,
yeah.
yeah, the same with monkeypox. I mean, things started only when it moved to the developed countries. So this is not fair. No one is protected again unless everyone is protected.
Absolutely. Well said, Doctora. Thank you. We'll move to Dr. Emmanuel. Dr. Emmanuel, with the precautions you mentioned, do you advise having a frequent visit by the medical team, or should we minimize the encounter time? Or can we use the AI tools to look after these cases? I've seen some healthcare providers ordering frequent labs, and that will bother Dr. Stephen, of course. INR and CBC every 12 hours for mild cases of Ebola previously, and the patient did not have any sign of bleeding. So what's the best practice with such dangerous cases?
The really important question, and I think the question you did link to the question I put in the chat about telemedicine, really useful if you've got, given the infectivity and how rapid it can progress, we wouldn't want to use telemedicine for somebody who's symptomatic at home. If it's somebody who is under quarantine, asymptomatic contact, then telemedicine is reasonable. But if they're symptomatic, they need to be brought into hospital and isolated because of the risks to the community. And now, once in hospital, and your question about using AI tools in telemedicine, I think is really important. You want to limit exposure, and the more frequently staff are going in, the more frequently the risk of exposure, because donning and doffing is not a straightforward process. It needs a checklist. You need to do it religiously. Also, the environmental and human factors that may make you breach your donning and doffing. And the most risk is when you're doffing, actually. So you don't want frequent visits. And that's why I said in my talk that you need to, as a team, plan when people are going to go in and who is going to go in. And when they go in, they can also multitask. So a doctor can actually go in and take vital signs and deliver food, not go in and come out and expect a caterer to go in and deliver food, or a nurse to go and do vital signs.
I like this coordination.
Coordination.
We work as a team, yeah, of course.
Yeah, and similarly, the use of telemedicine. If the patient is relatively well, you don't need to go in to check on the patient. You can phone the patient. You can use video recording tools to check on the patient. Or the patient can even call. And also, there are also tools in high consequent infectious disease that are well developed. They can do remote monitoring. You don't need to go into the vitals with probes that attach the patient, and then the heart rate and blood pressure, you can measure it remotely without having to go in with your tools to go and measure the vital signs. So you need to have a process in a high consequent infectious disease unit to limit exposure, because nobody is perfect. Even when you're well trained and everything, you can still go in and breach your PPE. And the main means of transmission of Marburg is through contact. Airborne is a minor thing, and we use N95 always, but because of how serious it is, and you don't know whether your patient's coughing and airborne, so you would use N95 as a rule, but the main issue is contact. And so it's mainly using your level 3 or level 4 PPE well, and doffing appropriately.
Thank you, Dr. Emmanuel. Going to Dr. Huda. Dr. Huda, should we stay 1 kilometer away from the caves? Or what should we do with the bats?
I think depends on your interest. You should not, of course, take risk in highly endemic regions. But we know that bats do travel geographically between areas, and things can move around. So staying cautious, especially in caves that are known to be infested, and especially caves that are not visited frequently. So not kind of a cave that is known and well structured inside for tourists.
I agree with you. Bats are not pets. We should just live away from them. But you mentioned in your presentation that bats are not badly affected by the virus. So what are the protective factors they have which we could learn from and develop something out of it?
I believe research is still ongoing with regards to understanding Marburg infection in reservoirs, and mainly through serology of bats. That's what they found, that bats who are not infected, who didn't look ill, were positive in terms of serology and lived longer and even gave birth to new bats and were more infectious during birth process. So I think there are lots of questions with regards to immunology and how body responds to Marburg infection that needs more research to be answered.
Thank you, Dr. Huda. Dr. Stephen, my last question to you. When you spoke about the specimens, if you have a specimen of Marburg virus, how would you discard this specimen in your lab?
So we have an autoclave, yeah, and as I said, every specimen that we have and that will be done with the PCR is inactivated before that. So that inactivation step reduces the risk significantly. It doesn't bring it down to zero, but it reduces it significantly. And we do not store these samples as we would usually do for 5 to 7 days or so, but it will be immediately autoclaved and then it's safe.
Thank you, Dr. Stephen.
Yeah.
Dr. Nawal, since we have since Ebola virus and Marburg, they have similar characteristics and they came from the same family, would we use approved medications for Ebola to treat Marburg virus, like the Enmazab or something like that? Enmazab, yeah.
Unfortunately, it is a possibility, but unfortunately, what's been approved for Ebola so far doesn't work very well for Marburg. There are studies ongoing that maybe will be able in the future to use the same vaccine, but it will be like multivariants to prevent 4 types of viral hemorrhagic fever, the 2 types of the Ebola, the Sudan and Zaire strain, the Marburg and the Lassa virus. But currently, unfortunately, it is not effective against the Marburg virus.
Thank you, Dr. Nawal. I'm just going to ask Dr. Farhan the last question, and then we need to conclude the meeting because of the time. Dr. Farhan, I received a question. Is there any asymptomatic transmission like the COVID cases for Marburg virus?
No, fortunately, no. And I think that is one of the reasons why we don't see big outbreaks like we see in COVID. Because had it been asymptomatic patients start spreading the infections, I think the outbreaks would have been much, much more larger. Because the patient would not be knowing that they are infectious, and then therefore the patient would be spreading the infection. So luckily for us, they start becoming infectious when they are in their peak, or at least when they are symptomatic as such.
Okay, thank you very much, Dr. Farhan. So I would like to thank each speaker, Dr. Huda, Dr. Nawal, Dr. Emmanuel, Dr. Stephen, Dr. Farhan, and Jennifer for their time and contributing to this session. And I'd like to thank Emirates Society of Infectious Disease for the collaboration. I hope that we managed to cover the major aspects of the session. Please stay safe and have a good night. And we'll see you, inshallah, again in another session. Thank you very
شكرا
much.
دكتور شكرا يعطيك
Thank you. Thank you. Thank you. Thank you.
Thank you.
Thank you,
Nice.
everyone. Salam.
Thank you.